And I'd like now to initiate, please come up, a discussion. Firstly, by asking, come on, the three of you, is there a Bangladesh model that is exportable to other countries?
Want to say something? The straight answer is no, but it's not a model that we want to export. It is the lessons, and that's, I think Victoria's done a very good job in summarizing those lessons. That you have to invest in health interventions. I mean, there's no way out of that, but it has to be done in the context of investments in human capital, and that is key, and that has changed the way we have worked. And the other key lesson is, and having NGOs as a key partner, I think that in itself makes Bangladesh very unique, and I think that's a lesson that can be used elsewhere as well. Having a non-state partner very active and helping where the government can't do certain things.
Yeah, before going to Bangladesh, I worked in Indonesia, and there were almost no rural NGOs functioning there. There were some small NGOs, mainly with reproductive health services in the city, in Jakarta, for example. But basically, the government model was it. And as a researcher, it was very difficult to even criticize the government model, and I discovered to my peril that you probably shouldn't do that. So Bangladesh is totally different. You can say anything you like about the government program. You can be critical of it. They may listen, they may respond, maybe not. But you've got all these other NGOs out there trying different ways of delivering services and experimenting. And then you have a number of the donors, some of whom totally bypass the Ministry of Health and just fund networks of NGOs. The British were doing it. They had a large NGO network for a long time. The Americans, until very recently, bypassed the Ministry of Health completely and just funded a whole bunch of NGOs to deliver services. The problem with NGOs is that you're never quite sure what their coverage or catchment areas are, particularly in the cities. And they will often claim to be providing services to a huge number of people, and it's very hard to know exactly if that's true or not. But as Victoria said, Bangladesh is well endowed with now very good data collection systems, so we have a fair idea of what's going on. Another thing that wasn't really mentioned, but I think is important, is there has been a great deal of economic improvement, but it's really been at the household level. So there have been massive increases in remittances back to the rural households from young labour migrants, particularly to the Middle East, but increasingly to Malaysia, to Korea and other places. And we're talking billions, tens of billions of dollars a year coming back, and much of that is coming to the rural households, and we're starting to see an impact of that. And then you've got areas like the garment sector, which are predominantly around 90% of the garment workers in the textile factories. And I walked past H&M the other day, and many of the clothes that you'll find in H&M are made in Bangladesh by these underpaid workers, but they're still getting paid. 90% are young women, and there are all sorts of benefits of having those small amounts of cash, and I think that's translating. So when you see gross figures like GNP, in many countries that it may be just a few of the wealthy and the factory owners and so on who benefit from that, and there's no doubt that's also happening in Bangladesh, but it's also getting spread around, at least from a very low base. So we're starting to see people being much better off, in addition to the provision of a variety of types of health services through NGO and government.
Yes, is there a model that can be exportable? I think there's some things that can be directly, translated, especially the biological ones, the interventions, scaling up of immunization, access to antibiotics for pneumonia, ORS. But then some are contextual, and I think it will depend on what works for what country. But I think that NGOs, they can do a pretty good job.
Questions from the audience. Yes. There's a microphone wandering around here. So.
I just started talking. Oh, okay. Thank you for your
Please
presentation.
identify yourself.
My name is Kathleen, and I'm from the Maastricht University in the Netherlands, doing a master's in global health. Thank you all for your presentations. And I was wondering if you can comment on how the government and the NGOs would navigate the political space when it comes to delivering or providing maternal health services. So is there potentially another political agenda if an NGO comes in to provide a service, or really what kind of incentives are there? Thank you.
Again, when I first went to Bangladesh, it was with Population Council, and we had to register. We were opening a new office, we had to register. And at that time, the government's idea of NGOs was that the NGOs should go and work in remote, hard-to-reach, unattractive places that flood and where there are no roads and all that kind of stuff. So the NGOs would fill those gaps where the government either cannot or doesn't feel like providing services. That's been the theory, but if you actually look at where NGOs work, you know, the majority of them work around close to the capital city. So they don't, that idea doesn't work. And then you had a problem that, well, how do we fund the NGOs and all this kind of stuff? So of course, there for a long time there was a feeling, and I think it still persists, that the NGOs are diverting donor funds which would otherwise go to the government, putting aside the fact that many of the donors would not actually fund the government. They fund NGOs because they don't want to fund the government. But that idea is a bit hard to convey to government workers. But we noticed when I mentioned in the year 1998, 1999, the sector-wide approach started. And that was a whole new way of doing business. And it required, in the initial year, it required training vast numbers of field workers in the new essential services package, which was basically primary healthcare package. So the government realized they had committed to training 60,000 health workers for 2 weeks training. They had no capacity to do that. So the government says, well, we'll just contract the NGOs to do that. And then somebody read the fine print and said, well, government can't subcontract NGOs. They have no mechanism to pay government funds to NGOs. And it took probably 2 years for them to work out a mechanism where they could actually divert government money to NGOs to do these kind of tasks of, you know, large-scale training and so on. Those initial problems have now been overcome, and they're starting to work together, but there is a lot of tension between accreditation for success. You know, is it the government program or the NGOs taking credit for what the government's really doing and this kind of stuff? So there are still tensions, there's no doubt about that. But the combination of the two seems to somehow work in some areas. I'll just mention one other thing, because we heard from the DG of NORAD this morning about, you know, the growing importance of NCDs. And we know from a number of sources, including our demographic surveillance, that about 70% of deaths in Bangladesh are due to NCDs. But if you look at the government budget, it's only 4.5% of the government budget goes to NCDs, and 70% goes to maternal child health. So there's been a massive investment. The current 5-year budget is $7.7 billion US. So 70% of that goes to maternal child health. So the government really has made major investments.
Yes. Okay.
Thank you. Okay, my name is Phyllis Awor. I'm from Makerere University. I'm completing my PhD in University of Bergen. But I would like us to discuss a little more the fact that relating Sub-Saharan Africa and maternal mortality reductions, that economic transformation in Sub-Saharan Africa might be a whole generation away. That's a lot of years. And maternal mortality, yes, reduction is, the need for it is immediate. How can we go about that? The issue with NGOs has a lot of challenges. I know, if you don't have government health system-wide strengthening and the like, but what in this room, and especially all of you, how do we complete or meet the unfinished maternal mortality issues in countries that have 20 years or 25 years to actually have any economic transformation that is meaningful?
Thank you very much, Phyllis. Very good question. To begin with, I think we have some. I think I'll reach for the low-hanging fruit first, and one of them is access to these to services. Even though we seemingly have better, higher proportion having skilled attendants at birth, it's still lower. It's still about 50% on average. And in areas that actually have the highest deaths, it's way below 50%. So if we could, get women to health facilities, then perhaps we could see, and to health facilities that have also good services, then we could have some effect. Now, the question is, how do we get women to health facilities in the short term? And again, I'll go for a low-hanging fruit, which is the community health workers that we have right now, and for whom we are giving. If you come to Uganda, you'll see that the community health workers have huge binders. I mean, they have so many tasks that it's impossible for them to do. But if we just summarize their tasks into, just a few but hard-hitting issues that they attend to, if they could go and encourage these women, to plan for a health facility delivery, to get ready to go to a hospital early on, and it doesn't happen, that, okay, now I'm in labor, what do I do? But, to plan beforehand early on in pregnancy, prepare them to go to a health facility, perhaps we could see some increases. And we do have community health workers, except that either some of them are not active on the ground, or those that are active, they have too many responsibilities that they can't actually do all of them and do them effectively. And then, of course, the other one would be to increase the quality of services at the health facility. And this includes improving the facilities themselves, but also increasing the proportion of health workers. This is really political will to a great extent, and increased funding into the health sector.
Yes.
My name is Margit Steinald. I work in Tromsø and Cambodia. I'm an obstetrician. I have a few comments. Norway and Scandinavia were able to reduce the maternal mortality rate and the infant mortality rate long before we became rich. So it is mostly a question about political changes and the empowerment of women. My great-grandmothers delivered in the ocean, not in the ocean, but in little islands. And that was because they were afraid of the midwives, they were afraid of the doctors, and that's what I meet in Cambodia as well. I mean, trained health personnel act in an abusive way towards poor patients. So why would you ever spend your hard-earned money to go to a doctor or a midwife who beats you or just tell you that you're stupid? So I think we have to address that as well. What we see in Cambodia is that the salaries for a skilled midwife, a senior midwife who has delivered hundreds of babies, is $150. That's just a little bit more than the garment workers. So they have to have their private clinics. They have to grow their own vegetables. They have to raise the pigs to pay for their own children's schooling. So unless we raise the salaries for the public health workers, we will never be able to beat the growing private health sector, where the rich people can always buy their way out of trouble. So it is we have to address this in a very, very broad perspective. Thank you.
No. Let me call on people here. Yes, please. In the front.
So I'm sorry to take up your time, but I must congratulate you. That was a terrific set of presentation. Really is. I mean, the Diarrhea Institute from Bangladesh has been at the forefront of our understanding of diarrhea and all of the things you said. My questions really relate to some of the things that came out. So I learned a lot about what you've spoken. But I really remember your comment about what lessons does it hold. And the important thing is it holds some lessons, but not all lessons. Don't try and reproduce it. And some of the things that concerned me was like, the private sector is a double-edged sword. I know you need to have partners. You got to come to South Africa. I don't know how many of you have been to South Africa. That is a major threat. If you take 100% of total health expense, we've got the largest proportion in the world of private medicine, and that is heavy stuff. 80%, 90% cesarean sections in private hospitals, 15% in public hospital. Similar, not identical population. Doesn't make sense. They're ruining a whole generation. And I was also worried about your comment that, these workers are being paid a slave wage, and it's okay because at least they got a job. That's what they use in South Africa to rape our country, because they gave those miners,
Sorry, I didn't say it's okay. I said that's how it is.
Well, but that's still not making enough of a case against it. It's a danger. And that's what happened to mine workers. They are earning 12,500 rands a month, and the bosses are working away. The CEOs are talking about 28, 30 million rands. So you have to deal with it. And when you're talking about upliftment, I think that's a critical part of upliftment. The last thing I wanted to ask Sham, because I really liked what you said and what you did. But I reviewed a paper for the Lancet. You'll guess what I mean, but I don't want to repeat it. And it was done on the other side of your section. Also perinatal mortality. And they threw everything in the book that you mentioned. And the gains they got was so trivial that it wasn't worth the cost. And we wrote a editorial or commentary, whatever you call it, in the Lancet saying, there's something wrong with the system. And I think the number of comments came back. See, you can't find technocratic solutions to some problems. You can do it, give the health thing, but unless you solve the sort of socio-economic, what I call the social determinants of health and all of that, you may not make a difference. And I wanted to know what you thought of it. I'm sure you know what I'm referring to. So.
Otherwise, it's private conversation.
I'm not going to. Maybe we'll have to have a conversation about the other analysis. But I think it is a difficult area to attribute impact for many of these factors that we're trying to understand very well. And I think and that's all I'm going to say about that particular piece. In terms of your I think the key lesson for us, for me, from my perspective, I think the key issue is that, and I'll give you an example of, for example, if you look at maternal mortality as an example, what makes a difference between in Bangladesh and Uganda, and maybe it is not just the fact of the education being different, which helps, but maybe it's also an issue of transportation. When I was young, very young as a boy, to take ages to go to my grandmother's place. Now, you can, if you ignore Dhaka's traffic, you can drive from the capital Dhaka to any part of the country and come back on the same day. So that's the change that has happened. It's easier to go from point A to point B. And I think that makes it easier to reach services when they feel they need it. So even at overall low rates of use, I think there's a lot of self-selection, which probably is helping out in terms of reaching service to those who actually need it. So even if skill budgeting is still at the 30%, I think most of the women who may need surgical help do get that. And when and Kim was referring to this issue of the case studies we did as part of the 2010 survey, and almost every case that we looked at, there was care seeking. However, the system failed them, and often we saw them arriving at late at night when nothing was there, nothing available, and they died before healthcare they could receive any proper healthcare in the morning. So the focus has to be in 24/7. So that's one issue on that. The other thing is that one of the things we have seen, and this goes to this issue of private sector, and I'll respond to that question, is it is very worrying to us, this pattern that we are seeing. I personally don't think that we have any likelihood that we can regulate that. The country like ours, I don't see that happening. And what we see can happen is potentially is provide competition in the public sector and get their act together in terms of providing better care, more accessible. I think maybe that would change it, but I don't see whether we can achieve that with regulation. But maybe we can have a conversation later on to follow.
Just a brief little comment on the last two, on some of the things you said and what you said. I mentioned before that from 1990 to 2000, there was a major investment in upgrading facilities for both comprehensive and basic obstetric care in Bangladesh. And I was involved in the DHS in the year 2000, which showed that there was absolutely no change in facility delivery over 10 years. And a lot of the doctors involved in this area, especially the Obstetrics Gynecology Society, were screaming, saying, what is wrong with these people? We provide these nice facilities. They know that they'll be delivered, hopefully, reasonably well in these facilities, and they just don't come. What is wrong? They're behaving irrationally. And I couldn't resist making a little simulation. At that time, because we have early marriage, low fertility, a young woman would be pregnant for the first time at about age 18. In a typical village, which is average about 2,000 population, she would know, since she's been of reproductive age, say 5 years, in her past 5 years, she'd know 300 women in her village who delivered, and only one would have died. This was in the year 2000, only one. But she would know at that time about 30 or 35 families who'd gone to a facility and delivered, and 10 of those families would have been bankrupted by that. Now, is she irrational? She's thinking, I know one woman who died, and maybe there were explanations like she didn't pray properly, or she was something or something or something. But she'd know 10 families who were wiped out. They would have had to sell everything. Now, is that irrational behavior or not? I don't think so.
Yes. Yes, please.
I would like to thanks to
Please
Professor
identify
Shams.
yourself.
Sorry, I'm Shahinul Islam. I'm actually from Bangladesh, but I'm doing PhD at the University of Bergen. I'm completely not relevant with these topics that seminar is going on. I'm actually a cell biologist, but I would like to ask some of the things that really I didn't understand. But first of all, I would like to thanks to all of you that it was very nice presentation from all of. Yeah, but some of the presentation was contradictory that I found from Professor Shams and obviously Professor Peter, probably, yeah, if I'm not wrong. And that's I would like to actually address about the maternal mortality rate. There's Professor Peter mentioned that in Bangladesh now, there are more than 75% mothers are going to for C-section.
In a private sector.
In a private sector, and I think...
Those who go to
yeah, if 75% is going to C-section, and those mothers is, probably without risks of mortality. And so, how you actually achieve the MDGs in that particular point, where the 75% can interpret your results differently about the mortality rate, and this is one point. And another point about the NGO that Peter mentioned, that maybe Professor Shams have fascination to NGOs, and you also mentioned that the NGOs, the funding authorities from the outside of Bangladesh, they are probably maybe willing to give money to the NGOs instead of government, because the government may be not working well and NGO is working fine. But you also mentioned that it's sometimes very hard to find that how the NGOs actually working, and how, the area, how they are covering, and this stuff. And if it is so like that, that means they're working, their functionality is a matter of questions. And if it is so, then why you mentioned that Peter Shams, maybe I didn't understand this 2 point, that how you can address these two things.
Well, I think your first point speaks to question whether facility-based deliveries have had much of an impact on maternal mortality, period. And I think the talks nicely outlined why other factors may have had a major impact. But I will let Shams or Kim tackle the second question. Shyam's body language, he's walking off the stage, so
Come on, Shams, you're the doctor. What you want in a country like Bangladesh, if you have low levels of facility delivery, ideally you want the women who go to the facility to be the ones who need to go, who have a problem which can be resolved in the facility, and maybe if they didn't go to the facility, they'd have a major problem or they'd die. That's what you want to happen. When you're talking about 75% of deliveries with C-section, you know that a lot of them are unnecessary, and they're for convenience and therefore other financial gain and this kind of stuff. So what you hope is that at least among the 75%, hopefully some of them are women who actually need a C-section. We don't even know what proportion of all pregnant women will need a C-section. There's a WHO estimate. We've had another estimate which is even lower than 1%. A study that was done in the 1990s in Bangladesh. So we don't even know actually how many are necessary, but it's probably very low. Your second question, I had an answer to that too, but I can't remember what the question was now.
take it offline. Other questions? Yes, please. First you, then you.
Thank you. It's Betty Kirkwood from the London School of Hygiene and Tropical Medicine. I'd like to ask, it's a wonderful inspirational story from Bangladesh, particularly to see what you can achieve through a community-based approach. I'd like to ask a post-2015 agenda question. How do you see the same approach being used to promote early child development? And are there plans in Bangladesh to do so?
Shams, you're director of Child and Adolescent Health at...
The floor is yours, Shams.
Betty, I don't think I have an answer for you there. I think it's going to be a struggle. I think there has been fairly spotty experimentation across the country by different entities trying to do that at scale, but I don't think anything is at scale yet. And I think that's where, in general, I kind of blame people like us of not getting our act together and making sure that we have something that we can actually go to the government and say, okay, let's try this model and go with it nationally. We haven't done that. We continue to experiment with studies and trying this and that but no, I think there's enough human knowledge that we can actually go out there and say we need to do this, but that doesn't happen. So I don't have an answer for you, but it is a real concern for several of us.
Back of the room.
My name is Akhtar Hussain. I'm a professor at the University of Oslo, and actually originally I'm from Bangladesh as well. And I have one question and some moments to share with. One is that that the data that you are collecting is from Matlab. Matlab is known since I was a student. And I don't know, maybe you have the data from Bangladesh as a whole, but if it is a Matlab, if it is not Matlab, then it's okay. The other thing that I was wondering that about the coverage that you are talking about, we are doing a study in Bangladesh on behalf of the European Union, and including 17 other countries around the globe. And we have done in stage 1, we have done a study where we found that about 50% of the mothers will come to the delivery facilities. But after that, we have made the doctors to talk to the patient and providing them the assurance that they will be taken care at the time of delivery. Now we have delivered about 700 pregnant women, about more than 95% of them delivered in the hospital. So I think there is a potential to improve. But my question here is that I'm actually from the area of non-communicable diseases and particularly diabetes, and we are trying to see the fetal programming for diabetes. And in that study, we are finding that about in the pregnant mothers, they are aged 18, they say, but we believe that they are younger because they don't want to say that they are younger than that because of the legalities. And they have a BMI of 19, and 7% of them are found to be diabetes in the first trimester. What is the impact of this gestational diabetes or undiagnosed diabetes before delivery in terms of mortality? Do you have any sort of data? But in such conference where we're addressing the maternal mortality, we are not addressing the issue of gestational diabetes, which actually accounts about 10 to 30% in different countries. Thank you.
Yes, thank you. In response to your interesting comment about reassurance from doctors. In essence, that's very similar to the MATLAB model, where reassurance comes from community health workers and doctors, and where over 70% of births occur in facilities, whereas countrywide it's 30%. With regard to the latter question, a great question. We now have a large cohort study to actually address that issue in Bangladesh, but don't have results yet. Questions? Yes. Yes?
Hi, hi everyone. My name is Andrea Sones from now PhD student at the University of Oslo as well. I have a question for you, Victoria. In your wonderful journey to identify the lessons learned from Bangladesh, I wondered if Bangladesh could learn anything from Uganda.
I think one would be we have higher attendance at skilled deliveries and postnatal care, that's for sure. Whether or not that's has worked for us is a different question, but we have been able to get more women to health facilities at birth and also after birth. And want to learn from us? I guess.
I'll make one comment. Yeah, I think it was a clever question. Congratulations. But also a very good question. I think it really underscores the importance of South-South collaborations and relationships, which I think have been relatively underutilized in recent years. Kim, did you?
I mean, one striking example from a comparison of Africa to Bangladesh is the use of nurses and midwives. We're one of 6 countries that has fewer nurses than doctors, but we have such a problem to get doctors out in the rural areas and to keep them, for them to stay there, you know. So obviously nurses and midwives would be really, really beneficial to us. Yeah. No, that'll do.
Just to add to that, officially we have no midwives with 3-year training in the country.
Other questions? Yes, please. you won the lottery.
Thank you very much. My name is Pia Axemo. I am a lecturer at University of Uppsala and obstetrician. And I have also been worked in a lot of African countries. I have one question that you will be surprised, because you are talking about women empowerment and she will go to the health service, she will do this and she will do that, as if women empowerment is already there. And also, I would like to ask for another. Long time ago, we asked for where is the M in maternal and child health. Now I would like to ask, where is the man in maternal and child health? Where is the father? Where is the man awareness? Where is the male involvement? Who is the decision maker, the power over the finance? So that was my question to you from Africa and Asia.
Shams, can you do the marathon back here? Okay.
I think maybe one simple part of this discussion in response to this is, I don't think the decision making is ever in a family ever made by one person, and I think what has happened is that as we have invested in the woman in Bangladesh, the balance of decision making has changed over time. But it's never was a single person. It never is a single person. But the discussion probably is different. I wish we had cameras and audio recording of what actually happens. We don't. And surveys are horrendously incapable of picking up the actual decision-making process. So we don't know. We can guess. But my guess is still is very much a family decision. But that family decision is much more strongly influenced by, more educated, informed women. And I think the other part of it is, care seeking is, especially for maternal health, care seeking is much more convenient now than ever before. Be it knowing where to go, when to go, and how to go there, and knowing that you can come back if needed the same day. Those are issues that help trigger the right decision, and I think that is helpful. And again, this is pure speculation at this point.
Yes, female empowerment is definitely not where we want it to be. It's still way below where we would want it to be. And that is a work in progress for sure. About where's the aim? Very good question. And some work is being done. We, in my group, we are, with funding from the Research Council of Norway, are conducting, or are in the process of conducting a randomized control trial where we are actually targeting men during pregnancy to help with these decisions and with supporting the women for birth. But we also don't have data yet, but we will have some data.
Additional questions? Back of the room?
Hello, my name is Gavin Yamey. I'm a professor of global health at University of California, San Francisco, and I lead a project called the Lancet Commission on Investing in Health. And my question relates to your comment about South-South relationships. One of the most distressing, alarming recent global health stories has been India's announcement that it's cutting its public spending on health by 20%. Public spending on health was already very, very low. And I'm just wondering whether there are any lessons from Bangladesh, sort of around the political economy, how political interest in health was fostered. Was it related to demonstrating, for example, some of the economic returns or social returns to these investments? You know, how did it happen, and where might there be lessons for India to try and avert the catastrophe there? Thanks.
Yeah, I don't know. You know, we don't have a very high per capita budget for health in Bangladesh either. We do have both a prime minister and leader of the opposition who do care about these issues, and I think that translates to some degree. We also have the presence of a great many donors who provide a certain amount of funding, although that as a proportion of overall health budget, it's declining. It's probably around 10% now. But so I don't know how to answer that question. This is the guy who can answer that for you.
I can speculate.
Yeah, please go ahead and speculate.
I don't think we have any lessons for India. I have no way of figuring what exactly triggered the decision by the Indians, you know. But what I can talk about is what is happening in Bangladesh in the sense that we have active discourse all the time, and I think and it's very great reliance on evidence and data. So I think that helps, and I think and I think the more we go there in that direction, and in all countries, it should get better.
Front of the room.
Thank you very much. My name is Jeanette Magnus. I'm from the University of Oslo. Thank you very much for a very, very nice, entertaining and exciting presentations from all of you. I'm very, very stunned of the great amount of data that you have. But then the first presenter talked about this East-West disparity when it comes to women, when it comes to the education. Then another of you talked about the increase of domestic violence that you didn't quite know about. Also the increase of women suicides that could be masked homicides. And then we talk about empowerment and the ability of the woman to negotiate. Do you have sufficient data to check out to see if there has been an increase of domestic violence and violence related to this, that is some kind of retaliation because there is a change and shift of power in the unities at home?
Either of you want to?
There was some evidence of that when you heard the mention of BRAC, these big NGOs, and they targeted their microfinance programs to women. 70% of their members had to be female, at least 70%. There's anecdotal evidence that there was an increased level of violence within families when the woman would get a loan and then the husband would want to divert that loan to something else, and then he'd beat up the wife because she wouldn't give it to him and she had to repay the loan and all this kind of stuff. So, but I've never seen it quantified. There are specific types of violence like acid throwing, which are often related to marriage and marriage proposals which are rejected by the woman or her family. And we had massive levels of acid throwing for quite a few years, but that seems to have declined, and I'm not it's gone down dramatically, probably because a number of the perpetrators of this have been put in prison. I don't think it's because of any other social change that they've actually been targeted now, and there are Acid Survivors Foundation who are publicly exposing this practice. But there's still a lot of violence around dowry and non or partial or incomplete payment of dowry and that kind of stuff. So it's a tricky one to get, even in a surveillance area like ours, where the field workers come from the villages where they interview. They know exactly what's going on in those households, but we still don't get good information on homicide in particular.
I think we have time for one last question, a very enthusiastic question from the front of the room.
I'm Arushma. I'm a medical student from University of Copenhagen. My question has already been asked here, so I have a small comment. You cannot treat a person's illness or disease and send them back to the environment where they got the disease. Just like you cannot empower a woman and send her back to the society where she does not have her human rights. So it's a matter of opinion and change in opinion. And change in opinion doesn't come over time. It doesn't even come over generations. So my plea is to also have a huge focus on these opinions where women and girls don't have their human rights. Thank you.
Well, on that very inspiring plea, we'll now close this session. Thank you very much for your participation.